me, Dr. Soumik Goswami, an eminent endocrinologist from our city. I need to know that once we have a diabetic patient with established chronic kidney disease, we do have wonderful molecules as SGLT2, GLP-1, MRA, but can we really do without insulin as far as management of glucose is concerned? Because sugar control is as important as the choice of those drugs.
I think the answer is known to most of us that, of course, most patients with kidney disease have to be on insulin, because with kidney disease, you have a decrease in insulin secretion, you have increasing insulin resistance, and you cannot use a large number of the oral agents that we use otherwise. So for obvious reasons, for improving glucose control, we have to keep a lot of our patients on insulin.
The next question, and the last question, but it's probably not appropriate because you have to individualize the insulin, but we have such a lot of variety of insulins. Do you have any particular recommendation of type of insulin, premixed, analogs, or insulin is insulin if you can handle it well enough?
So of course, any insulin is always better than no insulin. Begin with a low dose, gradually build up to avoid hypoglycemia. But if you look at the individual insulin types, of course, the data shows that the analog insulins are better than the human insulin, both the long-acting one as well as the short-acting one, at least in terms of hypoglycemia risk reduction. Amongst the long-acting analogs, we have the best data with U300 glargine as well as with insulin degludec. They are very closely matched, very small differences between them in terms of the risk of hypoglycemia and efficacy. Amongst the short-acting insulins or the rapid-acting insulins, we have good data both with fast-acting aspart as well as with injection lispro. The data with glulysin is a bit mixed. So that is how things stand. And basal bolus insulin regimens have the best data in patients with kidney disease. With premixed analogs or with premixed human insulins, the data is lacking.
Thank you very much, and thank you for saying the basal part, because sometimes we see the patients are not given basal and the swing of sugars are really quite difficult to manage. Thank you very much.
Thank you.